discussion via YouTube video. Today we will discuss case 2, which is positive in our forum. As usual, I have a special guest today, Dr. Kashyap Patel. He's an internist here in the US. Welcome, Dr. Patel.
Thank you.
Thank you very much.
To be here.
Yeah, I've been working with Dr. Patel in the past, so he's actually also one of my very good friends here. In this video, I will go over about the EBM principle, review our case, presentation, and then Dr. Patel will go over current evidence and recommendation around cellulitis. And he will have answer the three main questions. What is the patient diagnosis, current treatment recommendation, and then treatment of cellulitis with abscess. So those are the three main questions. So let's review EBM principle here a little bit. First, you should have a clinical question, right, Dr. Patel?
Yes.
And then, for example, in this case, we do not know what is current guideline for mollustic cellulitis. Let's say you do know already, but you will tell us, right?
Sure.
Then we search for current medical literature on cellulitis treatment. Once we found one, we will evaluate the evidence. Is it good or bad? Should we use or we should not? So Dr. Patel will go over with an example. And then we will apply this recommendation to our practice. And then lastly, we continue to follow what our patient care and see is there any better or improvement outcome. Dr. Patel, before we begin, can you share with us your experience in EBM with your daily practice?
So, as a resident in the hospital, especially in the general medical floors, there are quite a few cases that you oftentimes see of people that are hospitalized for cellulitis infections. Some are more serious than others. And there are some cases in the outpatient setting too that we've seen in our clinic as well.
So if you have a clinical question, do you look up on UpToDate or do you find some evidence-based medicine sources?
I generally use UpToDate for most of my literature search, and there is also something called essential evidence, which is very concise, and it summarizes all the up-to-date evidence, more concise than UpToDate sometimes. But UpToDate has the drug monographs as well, which really helps in terms of planning your overall course of therapy.
And by the way, for those of you who don't know, UpToDate.com, it's a very common website that most US doctors look up for evidence-based medicine. Yeah. And we here, Dr. Patel and we have no relationship with UpToDate, just for your information, and we do not have any financial or any gift from them to advertise.
Nor with essential evidence.
That's right. So let us review the case, our case here very quickly. So here we have a 46-year-old gentleman, African-American male. He had a history of MRSA in the past, and he presented with 2-day right lower extremity tenderness, swelling, and erythema. He reported spider bite on the right calf 2 days ago, prior to the admissions. On exam, the patient had stable vital signs. You found an 8 by 9 centimeter warmed erythematous flag with a central fluctuant mass that drained pus or purulent material. Now, our first question for you today, Dr. Patel, what do you think is the most likely cause of this patient infections?
So there are some key factors in this patient's presentation that alerted me that this is probably cellulitis, given obviously the erythema as well as the fluctuant mass suggestive of an abscess. But this patient also has a history of MRSA infection, and this episode started with spider bite triggering his infection.
So is there a clinical trial or a study that you can look up and share with us what you think?
As far as studies go, there's one interesting study that was mentioned by Moran, which was titled Methicillin-Resistant Staph aureus Infections Among Patients in the Emergency Department. This was more of a prevalence study. It was not a randomized controlled trial for evaluation of any drug per se. This study was large in the sense that there were 422 adults that were involved, that were participated in the study. And most of these adults were actually only presenting with purulent cellulitis, not non-purulent cellulitis. So the study actually analyzed what are the characteristics of purulent cellulitis. 81% of these patients were found to have abscesses as they're presenting soft tissue infection. 8% of them did have cellulitis with purulent exudate without any abscess presenting. In our case, we have both cellulitis, surrounding cellulitis, with abscess in the center. So that can also be one of the common presentations. It was found that actually the causative microbe in most of these cases of purulent cellulitis was MRSA. It was 59% of the patients who actually were found to have MRSA infection. Interestingly, they tested sensitivities for many of these antibiotics, the more commonly used for MRSA infection. They found that trimethoprim sulfamethoxazole, also known as Bactrim for short in America for the trade name, they had 100% coverage, including basically sensitivity. So all of the 100% of isolates found in these patients, 59% of the patients with MRSA did have sensitivity to Bactrim.
That's very interesting.
Yeah. I didn't know it was as high as 100%, but I knew it was very close. So rifampin is another antibiotic which also had 100% coverage. And of note, clindamycin, which is also very commonly used for purulent soft tissue infections, had 95% coverage. So all three of these have pretty good coverage. You don't typically see rifampin being used as monotherapy. In fact, I never have seen that or prescribed that. The reason for that is that the MRSA bacterium quickly develops resistance to rifampin, like many other microbes. So although it's initially sensitive, they don't typically use it as monotherapy because of the problem of resistance to it. You can use it in combination, however, which is sometimes done. And of note, fluoroquinolones had only 60% sensitivity to the MRSA isolates. Not surprisingly, they're not recommended for purulent cellulitis therapy.
I agree.
So what are the risk factors that predispose a patient to having a MRSA infection? Well, obviously, history of previous MRSA infection is going to be a predisposing risk factor. In fact, this study isolated an odds ratio of 3.8, meaning a patient with previous MRSA exposure is 3.8 times more likely to have a MRSA-related cellulitis rather than not having a MRSA-related cellulitis. There are other risk factors, including specifically spider bites actually do have an odds ratio of 3.0 as well. So also high up in the list, and having any close contacts. Actually, the odds ratio for having close contacts with MRSA infection is 3.8. I correct myself. Previous MRSA history is 3.4. But you can take home the point that all of these risk factors are giving you a very high odds ratio of having a MRSA infection again.
So just want to remind you, so our patient present with those two risk factors, right? Dr. Patel, a spider bite, and a history of MRSA.
It is very suggestive of that, in fact. And the fact that he has an abscess, which we'll discuss in a minute, also has a risk factor of MRSA infection as well.
So Dr. Patel, basically he just went over a study, he talked about method, and then the results. So what are some limitations of the study? In any type of EBM, evidence-based medicine, you would like to look for method results, and then very important, you want to look for limitations. Because this is where you analyze whether this is a good or bad study, strong or weak study.
I agree with you. So they could argue that the biggest limitation of this study is it's not a randomized controlled trial to evaluate certain medications and how effective they are. This is more of a prevalence study. But I do think that this is, in addition to being a limitation, it's also one of its advantages. Because this way we can isolate the patients who have purulent cellulitis and see what are the characteristics that predispose them to this infection and what we can do about that in terms of which antibiotics have good sensitivity for the coverage of MRSA infection. So it's also a limitation, but it's also one of its strengths in that regard.
Wow. So any study look for, first of all you look for method, you look for results, and then limitations. So that's any type of study you look for before you can apply that to your daily practice. So let's move to the next question today. Dr. Patel, so what type of empiric antibiotic are currently recommended for treatment of cellulitis here in the US?
So, as far as the recommendations for antibiotics go, there are certain recommendations made by the Infectious Disease Society of America. We did already mention some of the antibiotics that are mentioned in that previous study, and you would wonder that whether or not you'd want to cover for MRSA infection. Well, the question arises, what exactly is causing this infection? Is it only MRSA, or are there other microbes that you want to consider? In skin and soft tissue infections, you can basically break down a patient presentation into purulent and non-purulent cellulitis or any other type of skin infection. The non-purulent types of skin infection are more commonly caused by Streptococcus species, including group A strep such as Strep pyogenes. The purulent infections are more likely due to MRSA infection. But nevertheless, they're most likely gram-positive cocci, causing some sort of skin and soft tissue infection in most patients. So, will your antibiotics cover the Streptococcus? Will they cover the Staphylococcus? Well, there are certain antibiotics recommended by the IDSA for specifically non-purulent cellulitis, including second generation anti-staphylococcal penicillins. These are the dicloxacillins and nefcillin. Or first generation cephalosporins, including cephalexin, which is an oral antibiotic. In fact, it's the most commonly prescribed antibiotic here in the United States. You rarely see dicloxacillin or nefcillin being used because the cephalexin has good coverage of the Streptococcus organisms. We did previously mention that Bactrim, which is trimethoprim sulfamethoxazole, and tetracycline, they have good coverage of MRSA infections. However, they don't have good coverage of streptococcal infection. So it's critical to, when you first see your patient and evaluate them, to kind of determine whether or not this is a purulent cellulitis or non-purulent cellulitis. And your management will depend on your determination, therefore.
So, and that's actually a very, very good summarize of the how do you classify when patient present with cellulitis. The key thing here is the Infectious Disease Society of America, they changed the guidelines. What we have here may be a couple of years old. So I recommend you to go over to their website, and they have 30 pages.
Yeah, it's I think it's 30 pages. It's it's a lengthy document, but it's very authoritative, and it's the latest guidelines from the society that deals with this.
That's true. That brings up a very interesting point. Can you imagine how many guidelines we have to follow for that? And then many of them are like 20, 30 pages.
Yeah, that's true.
When it's a guideline, it shouldn't be like one page, right?
It should be. I would really appreciate that if somebody created that for us. And that's where essential evidence really comes into play here. Something to summarize all of the evidence and give the best up-to-date recommendations, or up-to-date as well.
So let me review with you a very quick thing here, because Dr. Patel mentioned something about community-acquired MRSA versus healthcare-associated MRSAs here. So community-acquired MRSA, basically no contact with healthcare system, right? So you are in a community by yourself. It's called community. Right? Usually called purulent or abscess skin and soft tissue infection, and usually it's sensitive for bacterium, like Dr. Patel mentioned, up to 100%.
Yes.
The other ones, healthcare-associated MRSA. This is somehow similar to, we remember pneumonia, community now, healthcare-associated pneumonia. In healthcare-associated MRSA, patients usually contact in the healthcare system. They ICU patient, they nursing home, and usually they cause bacteremia, light infection, and resistant to a wider range of antibiotic. Usually they resistant to bacterium, clindamycin, and also
oftentimes.
Yeah, oftentimes. So now we move on to our last question here. So in patients cellulitis with abscess, pollen, skin and soft tissue infection, would you think it will make a difference if we treat patient with MRSA antibiotic beside IND, incision and drainage, which is a common treatment for abscess?
That's a very interesting question, and it's a very important question to answer actually, because oftentimes you will see patients more likely in the clinic rather than in the hospital that come in with just an isolated abscess. Mm-hmm. You incise and drain them, and then you ask yourself, does this patient need to go home with antibiotics? Will the infection get worse if I don't give them antibiotics? So let's look at this this study of done in children with abscesses that kind of tries to answer this question. It was done by Lee et al. And it was titled Management and Outcomes of Children with Skin and Soft Tissue Abscesses Caused by Clinically-Acquired Methicillin-Resistant Staphylococcus aureus. It was in the Pediatric Infectious Disease Journal, published in 2004. This was a smaller study actually. There were only 69 children involved, studied in this case series. 67 of these 69 children were managed as outpatient setting. So the vast majority of them had initial incision and drainage, and their overall care from beginning to end was managed in the outpatient setting. 5 out of these 67 patients, so about 7% of them, did receive antibiotics. Antibiotics that were actually found to be active against the MRSA that was isolated from their wound.
So that's very, like about 7 or 8%, very small.
A very small fraction of these patients actually. And not surprisingly, none of these patients required hospitalization afterwards.
So of course, I mean, they receive antibiotics,
yeah.
so expect not to come into the hospital.
Yeah, exactly. But the interesting 67, which is 93% of patients.
To the rest of them, basically.
Basically, the rest of them. They received an antibiotic that initially what they received was not effective against the MRSA infection that they actually had. And the interesting point is 6% of these patients required hospitalization. So 6% of the 62, whereas the remaining 94% of the 62 kids did not require hospitalizations. So statistically, there was no significant difference between the two groups. Mm-hmm. The small group that did receive antibiotic that was active against the MRSA, as well as the large group, the majority of which did not receive an antibiotic active against the MRSA, but did not require hospitalization stay.
Yeah.
Regardless of that.
No statistical difference.
They did find one interesting point is that the patients with abscess greater than 5 centimeters were more likely to require hospitalizations later on.
That's actually a very interesting point. 5 centimeters. If you think about it, how often you see this?
Yeah.
And then now go back and remember how many times we see that abscess and greater than that, and you get admission, right?
Yeah, that's it's very exceedingly uncommon, at least in the outpatient setting, that the abscess exceeds 5 centimeters.
Yes.
So we're talking about most of your presentations in the clinic here. They would apply to this study. I guess one limitation before I go forth with the conclusion of the study is that it only looks at the pediatric population. But we can take away some points here and possibly generalize them to some of your patients that you may see in the clinic here. Is that incision and drainage is most of the times adequate without requirement of any antibiotics, because more than 90% of these patients will require just healing on their own and no antibiotic to help overcome the infection itself. So essentially these pediatric populations did not require any staphylococcal active antibiotic, and they improved on their own. So I think that's the takeaway point, really.
So there's no need for antibiotic against MRSA, basically, if you already give a patient IND. Right. Which actually a quite interesting point. Sometimes you may wonder, should we give antibiotic or not? The answer here is no, if you already do an IND. So again, this is an example for you to look up on evidence base, and like Dr. Patel say, you look up and conclude from the study, that's what you can apply. So again, I just want to go over again, we have a question, then we look up, evaluate the evidence, and then apply to our practice and go, that's apply to our case.
Yeah, and I would just like to reinforce Dr. Tran's point here is that you do have to look at the limitations of the studies. I did mention that you may generalize this study to your population and the presenting patients in your clinic, but as in this example, you have to look at the individual patient. This study, one of the limitations I did mention is that they're looking at abscesses and there is no specific mention of whether or not there was accompanying cellulitis with abscess. So presumably these are abscesses that are simple infections and not as complicated by significant surrounding erythema. In our patient, he did have several centimeters erythema with a warm fluctuant mass in the center.
Actually 8 centimeters, just want to read that.
8 centimeters, yes. So that's pretty impressive. And you always have to use your clinical judgment and keep in mind the limitations of the studies that you evaluate in terms of making a medical decision. I would advocate treating this patient with MRSA active antibiotic, in addition to, of course, the initial drainage that you would do, because this patient possibly has a complicated cellulitis.
Wow. Thank you very much, Dr. Patel. That's a pleasure. And again,
it was a pleasure to be here.
It's Dr. Tran again from VietMD.net, and our special guest today is Dr. Kashyap Patel. He's here, an internist here in the US. Thank you again.